Welcome to Healthcare Forward, where industry leaders, benefit advisors, and healthcare professionals come together and discuss the changing landscape of commercial health plans. Brought to you by Roundstone Insurance, the first group captive for health insurance, where smarter self-funding meets long-term savings. I'm Mike Schroeder, founder and president of Roundstone Insurance. Well, hello everybody, and welcome to Healthcare Forward. I'm Mike Schroeder, founder and president of Roundstone Insurance. And we have a fun conversation today with Dr. Berry. The topic is reinventing primary care, the DPC revolution. Dr. Berry, our guest, is a primary care physician, as you might guess, and he's also an expert in DPC, or what's known as direct primary care. He works there with Maple Health, and we're going to chat a little bit about this idea known as direct primary care. Welcome, Doctor.
Thank you for having me.
So I guess we probably should get started and discuss a little bit, what is DPC, or what is direct primary care?
It's just a new way of delivering primary care to individuals. So we're kind of very used to what we call the fee-for-service model, where you've got hospital systems that own primary care clinics. You see the doctor. Unfortunately, at the moment, we're seeing longer waits, appointment time shorter, and then when you go and see those doctors, you've got no idea what the price is going to be for that visit, and neither does the doctor. So with direct primary care, we keep it simple. So we use a flat monthly membership. It allows us to have much lower patient numbers, so we can get people in for a longer appointment time. You can get in with the same person. You can get in on the same day. Because we're using a monthly membership rather than insurance, you know what your price is going to be. If you come and see me, you're not going to guess what the bill is going to be afterwards. You've paid the monthly membership. Everything that we do with our own hands is kind of included in that price. So it's all about just improving that kind of quality and access.
How long has DPC been around?
DPC as an entity in itself, it's actually been around about 15, 16 years. Okay. Historically, we've seen it much more in the metropolitan area. So if you were in New York City or San Francisco, people might be a bit more familiar, would have been around longer. We didn't really have a need for it in these sort of areas 10 years ago because doctors were available, the cost was reasonable, and you could get in when you needed to be seen. So as that has got more difficult, that's kind of allowed DPC to move really outside of the cities. And it's growing exponentially at the moment.
You know, it's interesting, the whole subscription model in business, it seems that it's going everywhere. I have a buddy that owned car washes, and he came up with the idea of subscription model, and it changed his business. How has this changed primary care, this subscription model?
It's really helping for people being able to budget. So if you've got someone who's got insurance, and let's say they have a very high deductible, if they end up going to their doctor, let's say 5 times in a year, they have their annual physical, they have a check for their blood pressure meds, maybe diabetic check, maybe an acute illness like strep, or they have an injury where they need sutures. Every single time they see that doctor, they know there's a bill coming, and they don't know how much it's going to be. And that's if they even got in to see that doctor. With us, it's about peace of mind and spreading that cost over the period of time. So that person, even if they needed to see me 7 times in the year, they are completely comfortable that they're going to get in quickly, they're going to get seen, the care's going to be excellent, and they know that they're not going to be getting tons of additional bills that they don't know are coming.
So why is it that your patients are able to see you a little easier, a little quicker?
All comes down to patient numbers. If we take hospital systems with their primary care doctors, they're normally looking after anywhere between 2,000 and 3,000 patients. So they just don't have availability in the schedule. For us, we build in availability into our schedule. So we actually have a maximum limit that any doctor can look after. So we cap everyone at 600 patients. So what that means is we can have availability on a daily basis for those people that call in with the urgent issues, and we don't end up with that backlog.
And let's talk about the time you spent with them, because I know that's different as well. A lot of times when you go see a primary care doctor, you feel you're kind of on a conveyor belt, if you will. Do you spend more time with the patients?
Yeah, absolutely. We book everything in 1 hour blocks. So if you were going to see me for an annual physical, that's going to be a 1 hour block. Even if you were just a follow-up of a high blood pressure, or you're coming in with a cough. We do everything with 1 hour blocks. Through the day, we can be quite flexible with that. So we know our patients very well. So if I've got a patient at 2 o'clock who I'm just checking their blood pressure and I know they're always straight to the point, they don't take too long, I know that if I see them at 2, I know at 2:30 I can have an availability to see someone who has an acute illness. And even those acute blocks, we don't do anything in less than 30 minutes. So comparing that to other health services, most people will be blocking 20 to 30 minutes for a full annual physical. Wow. And like saying, we never book those for under an hour.
Wow. Let's talk a little bit about the services. You have that meeting with the patient. What about things like labs or MRIs or other type of related primary care type services? Are those included? Are those part of the subscription model?
Kind of depends on what we're doing. So when we think about DPC, so I'm charging that monthly membership, what does that include? That includes everything I can do with my own hands. So you come to see me for an annual physical, no additional charge. Acute visit, follow-up of blood pressure, diabetes, that's no charge. Also procedures. So let's say we can do EKGs, urine tests, and even kind of surgical procedures. So let's say someone had an abscess that needed to be drained. They had skin tags that needed to be removed. They needed a steroid shot in their shoulder because they've got rotator cuff issues. We're freezing off warts and other dermatology. That is all completely included in the price. We don't charge any extra for it. We do have our own lab on site. That is an additional charge, but the charge is so much less than under the insurance model. So let's say we had an uninsured person and they got annual physical labs. You could be in the $300 to $400 for that. And even if the patient isn't paying for that, the plan is. We would do that full annual physical blood panel on site for $16 compared to hundreds. We have our own pharmacy as well. So if people come to see us for something as basic as a sinus infection, I can dispense those antibiotics straight into their hands. They walk out the door. Our most expensive antibiotic is $4 for a course. I mean, most people they're not going to get anything from the pharmacy for under 10 because of the copay. When it comes to MRIs, we then have options depending on the person. So let's take a couple of different people. Let's just say we have one well-insured person, one underinsured person, i.e. they have a very high deductible, and one uninsured person. If someone's well-insured, we can send them through any health system and get that MRI done. The underinsured person, we can decide whether we're going to go through a health system, in which case it could cost a couple of $1,000s because they're paying their deductible. Or we can send them to local cash pay places. So we can get an MRI done as cheap as $425. So if we take the uninsured person, for instance, if I send them to a health system, they get in there, they get an MRI done, could be $2,000 to $3,000, sometimes even more. We'll get it done paid cash for the $425. So we treat everyone as an individual, because if you're insured, underinsured or uninsured, that makes a difference. And also where you are in the year. So let's say we had someone who's underinsured, but they had their appendix out in February, they've already blown through their deductible, that opens up everything to them. Whereas if it's December and you haven't used any of your cost, we may even go the cash route for that person.
Right. Well, let's talk a little bit about the patient experience. And whether this model, whether you see patients be a little bit more persistent in their visits with you and in their care. One statistic that I'm always shocked at is that less than half of the folks out there in the employee working world have a primary care relationship at all. They're really seeing their doctor if they go to the emergency room or an urgent care. Does this model establish better relationships, something that's a little bit more persistent?
Yeah, absolutely. So our thing is we don't have patients that we don't see unless they have ignored all of our communication. So we actually have a setup in our office where when a patient leaves our office after a visit, they have to either have their next visit scheduled or we have a reminder in our system that tells me a month before their next visit is due to reach out to them. If people have an appointment and they don't show or something like that, every 3 months we go through that list and it's like, okay, when was this person last seen? When do they need to be seen? Are they overdue? So if someone's overdue to be seen, whether they like it or not, they're getting a phone call from us, a minimum every 3 months to be, you're due, you need to come in. So if anyone isn't, don't get me wrong, we do have some people like, I don't want to come in. I want you there available when I need you. I understand that you want to do all this other, like keep me healthy, but that's just the way I want to do it. And that's absolutely fine. But no one is ever going to not be seen because we didn't reach out to them or we didn't keep up to date.
What's the right amount of time to visit your primary care?
It depends. I mean, to be honest with you, you've got someone in their 20s, 30s, they're up to date with everything, they've got no health issues, their labs look great. We can just do if we don't see you in 12 months, we'll see you for your annual physical. We love to see everybody at least once a year so we can review when's a colonoscopy due, when's a mammogram due, all of those things. On the other hand, if we've got a well-controlled diabetic patient or a well-controlled hypertensive patient, we might see them every 6 months. Poorly controlled diabetic person, we might see them every 3 months. So it really comes down, again, everything's about the individual person.
Right. So obviously, if you have these relationships, people are seeing their primary care. We talked a little bit about the savings from a services point of view, but the bigger savings are avoiding the catastrophic, the really serious illnesses. And do you have examples of that where, hey, we were able to maintain this relationship, perhaps it's a diabetic, and get them back on the right track and avoid some more costly experiences with the healthcare system?
Yeah, and diabetics are the prime example for that. So when I was previously working under one of the bigger health systems, there was a few kind of complex diabetic patients that I could manage myself. I was capable of doing it, but I didn't have the time to do it because it's like, you've got 15 minutes, you've got to manage their complex diabetes, make sure they've had their colonoscopy, make sure they've had this, that, and the other done. And you just couldn't do it. So you ended up kind of having your hand forced to then refer those patients out to the endocrinologist, which is more cost to the patient, more waiting, and it's just not good care. Whereas now, I could have an hour with those patients as many times as I need to have it. And also keeping up on those patients. So most people have probably heard of the Libra system, which is the continuous blood glucose monitor. I actually have a setup in my system at work where I can literally monitor people's glucose monitors through my computer whenever I choose to. So if I've got a patient who I see this week and I make an adjustment to their insulin, I'll set a reminder in my own system in 2 weeks to go online, pull up their glucose monitor and see what difference it's made. And then I can just drop them a text, hey, this has improved, let's carry on. Oh, I see you're having a high or a low here, let's do this. So it just keeps those numbers better and just gives a better quality of care and keeps people out of the specialists that really don't need the specialists.
So how does Maple Health get your patients? Are the patients coming on their own, or are you working directly with employers? How does that come? Or is it a little bit of both?
Kind of a combination. If we look at our growth over the last 3 years, I would say at least 80% of it is word of mouth. So my patients from my old office, quite a lot came to me. They then started talking to their friends. Their friends joined. Now they talk to their friends and it extrapolates. So probably 80% is just word of mouth. If I turned off all of my media, all of my advertising, all of my reach out, we would still be growing at 80% our max rate. The last year or so, we've kind of seen quite a change in the business sector. So we're seeing many more companies now are looking to us as a solution for their employees. For the money saving is one thing, but then also that access. If we can turn around and say, hey, we can see all of your employees on the same day,
right,
it's kind of a no-brainer. Gets people back to work. And also by using DPC, especially for those self-funded plan, everything that we do in DPC, we're shielding the plan from a cost. So if someone goes to an emergency room for sutures and it costs the plan $1,700, but we put DPC in place, and that $1,700 is now no additional charge. Or rather than that kid getting sent to urgent care for a strep test that costs hundreds of dollars, then we're seeing them. So they're using us as not only a way to improve the experience for the employee, but also to shield the employer's plan from those additional costs.
And Maple Health, you're here in Northeast Ohio, right? But my understanding is DPC is becoming large enough now that for employers that have folks all over the country, you can establish a situation where they can find a DPC provider almost in any market out there. Is that fair?
Yeah, I mean, there's a few companies out there which are making all of those connections between these DPCs. And one of the examples is you've got a business in Florida. Their headquarters is in Florida and they've got 500 employees there. But they have a branch out in Willoughby, Ohio or something like that with 50 people in. They can make the main contract in Florida and then reach out to all of these kind of individuals. And then also locally, we can join together. So if I've got a company in Mena and I'm looking after the majority of them, but they've got 6 employees that live out in Beechwood or Westlake or wherever, I can then reach out to those DPC clinicians out there and just be like, hey, I've got 6 patients for you. And it's very easy to just connect across.
You know, that's a big deal because, Roundstone, we've been closely working with DPC models for a while, probably more than 10 years. And initially, the big challenge was geographically, it wasn't spread out enough. And so it was hard to make a commitment unless all of your employees were in one location.
Yeah.
And that change and that maturity of that solution has really been helpful to us. We're big advocates of it because we really do believe having a primary care relationship is how you have a healthy workforce and a healthy population within your company. So in fact, at our own company, we provide an incentive to the employees to reduce their cost share if they establish a primary care relationship. So, we're big fans of it. Let's talk a little bit about, so we have the employee experience, and generally it's positive. It sounds like they like it if they're coming back to you. Do you have an example you could share with me how you really kind of changed someone's health or, how it's a game changer for that individual?
Yeah, I mean, the biggest example I can give you is we had a business that joined with us. And when people come on board, we don't have the normal insurance restrictions. So insurance restrictions will be like, oh, right, we're not paying for a A1C to test for diabetes unless their sugar is this. We're not testing your blood count or kidney function because you're fit and healthy and you're not 40 yet. And these are all low-cost things, which I think are always good to have a baseline, because I've definitely had people under 40 before. I've done a blood test on them for whatever reason and found an unexpected low kidney function or something like that. So we actually did have one place where an employee group joined with us. We did some baseline labs on some of their employees, and we actually found a very aggressive, very serious cancer in one of those people who were under 40. And because we did those labs, which no other insurance would have allowed to have been done, we got so far ahead with that patient. I mean, it's going to make a critical difference. The fact that we picked that up on blood tests before there were any symptoms makes a 50% difference to the survivability of that cancer. Wow. So that's probably how big. I know that's kind of like a very rare one, but it's one that came out, and for that patient, I mean, it couldn't have worked any different. We were so far ahead of the game with starting treatment for this person. I mean, that just wouldn't have happened anywhere else.
And can family members be part of the DPC as well? Is that how you price it, by family or by individual?
We actually price it by individual. Okay. We did start doing it by family, but then we kind of hit the problem of what constitutes a family.
Right.
Like, we don't want to block people. So if you've got a grandmother looking after a grandkid, well, do they class as a family? Does it have to be two parents with a child?
Right.
Like, then you're like, what about single parents? So it got very complicated. So what we wanted to do is we just kept it to a strict limit, and basically what we do is we do some allowances if they bring multiple people in. So if I've got a family come in, they've got 3 kids or more, I'll give them a free kid, kind of as part of the deal, because they're bringing people in. But yeah, we don't do a specific family plan.
So let's chat a little bit about what we do at Roundstone. We underwrite health insurance. So our underwriters are familiar with DPC. And what they're always doing is they look at hey, what's the charge for the DPC? And then what services are they providing that we know are going to be replaced by this new relationship? And hopefully that's more than enough, and usually it is, to cover the cost of the DPC subscription. However, over time, we've introduced the idea to these underwriters that you have to give some consideration of what you're saving in the long term. So yeah, maybe in the short term you're saving on labs or some other things like that. But in the case you just shared, there's no doubt the care for that person was much less expensive than if they had discovered it years later, or at the last minute. And so our underwriters at Roundstone are able to give some consideration, some reduction, because what an underwriter does is just project claims, project expense for the population. And so taking into account, like, what is the impact of DPC going to have on the future expenses of this employer? They've been able to do it, and pretty effectively, and we see some really positive outcomes with the clients that are on the DPC model. It saves them money, and as a result, it saves them insurance costs. So it's pretty cool. I just wondered what your thoughts on all that. Is that a bunch of hooey in terms of saving money, or is it that's a real that happens?
I mean, one of the most common sayings in medicine is prevention's better than cure.
Right.
So if you're getting them in with us on a regular basis, checking on heart function, like ordering appropriate tests, following up with those tests, we are doing so much. We become predominantly preventive. So if we can prevent something happening down the line or find that thing earlier, then absolutely there's massive savings for the plan, but also savings in mortality and morbidity for the employee as well. So really everyone wins. Employer wins financially, employer has a healthier group, and the employee we're finding stuff before it happens.
Yeah. Let's talk a little bit about prescriptions and your involvement with that. Prescriptions are becoming a larger and larger share of the health plan cost. And in fact, they're the fastest growing cost, particularly specialty medicines.
Yep.
And it's ever important now to know, where you're buying your medicines from, and what type of medicine, and whether it's generic or brand and all that kind of stuff. Do you get involved at all with that? And you work with the PBMs and the patients to make sure they're buying it effectively?
Yeah, so we have our own pharmacy on site. So we generally stock the acute medications that we generally use for people that don't know they need it until they need it. So antibiotics, muscle relaxers, anti-inflammatories, prednisones, all of those things. And then we keep a stock of very common medications we use. So like blood pressure medications, some antidepressants, reflux meds, things like that. Most of those generics, we're very low price. So example, omeprazole, which is a basic reflux med, we can source that for about $5 for 6 months worth. And we buy that wholesale and we literally dispense and sell it at the price that we bought it for. When it comes to the PBMs, when we're doing more that rather than just the DPC doing the whole insurance model, the broker who kind of makes that product, they're then dealing with the specialty pharmacies. And there's a big combination of those. Some of them obviously sourced from different countries. There's lots of different ways to look at it. But yeah, we do see that's rapidly increasing.
So you can work with the PBMs and all that. Obviously, you can work with the networks. So
yes.
When they need services beyond primary care and they need to go into the hospital, as an example, there's no disruption there or interference. No, it's a smooth.
We can still order everything. So let's say your DPC come in privately to me, but you have your own insurance. If I send a medication to your pharmacy, the pharmacy will then charge your insurance. If I send you for imaging or like secondary care, so to a cardiologist for a stress test or something like that, all of those orders I put in are then charged against your insurance. So you're not stuck. If you come and see us, you're not stuck with not being able to use your insurance. You can still use it for all of those ancillary services.
So a real seamless integration with
Yeah,
the...
so I can still refer to PT, endocrinology, cardiology. I can still send meds. I can still order imaging, and that even includes Medicare as well.
So why wouldn't every employer do this? I mean, it seems like, what's
People don't like change.
Yeah.
And to be honest with you, it's not really the employer that needs to be making the change. It really comes from the insurance side of stuff. So you said about yourselves having your brokers that know DPC, understand DPC. Their job is to educate. Like, how can we make your population healthier? How can we improve your access and your quality and improve your cost? So it's not really, the employer wouldn't know about this. It's really, we need to be looking at the education of the individual brokers so they recognize it as something to use. Because if you have an insurance broker that's never heard of DPC, well, it's just not going to be on their radar to turn around to his company and be like, hey, have you ever thought of this? Because they don't understand it themselves. So we're in a kind of educational process at the moment, whether it's individuals in the community, whether it's businesses, whether it's brokers. And like I say, saying about kind of like getting involved with more the insurance. We've had no problem selling this from the personal memberships. That's
what is the price tag?
So I've got Courtney and Jordan who are open to patients at the moment, and they're at 70 for kids, 80 for up to 65, and then 90 for over 65.
You know how when we first started looking at direct primary care, those numbers were twice that.
Yeah.
And when we first dipped into it, candidly, our underwriters kept saying, Mike, I can't get, they want $175. And I just can't get because we like to basically, like, what we like to do is say, here's your insurance proposal without direct primary care. Here it is with direct, and it's actually less costly to go the direct primary care, and you're getting all these bells and whistles. And now at the pricing you're talking about, we can do that.
Yeah, and that's the problem, and it's very variable. Saying how much I charge is one conversation with me alone. It's not indicative. So you've got a lot of people out there who go, so you've got people who go into DPC for the DPC movement and to kind of drive that and to run a business like I run. But a lot of people go into DPC for the wrong, I'm not gonna say the wrong reasons, but they're like, I want an easy life where I'm only gonna see.
And I wanna make a ton of money.
I want 150 patients, I'm gonna charge them $300 a piece, and I have no intention of doing any more with it. And they're doing nothing for the DPC movement. They're just it's
a lifestyle choice.
Yeah, and also as well what people are doing. So we are very evidence-based medicine. So I'm not going to be coming in, pulling someone in from one of your plans and doing a 250-point hormone panel so we can dance around a fireplace burning some incense, with the functional stuff. And that adds hundreds and hundreds to the price at really no survival or mortality benefit. So a lot of DPCs, you'll find they're much more like functional medicine, like naturopathic, and they don't fit what we are trying to achieve. So to be honest with you, it sounds great. Oh, we're getting all these DPCs. 50% of them you probably don't want to be around.
Yeah, they're not. You've seen one DPC. They all different.
Because I spoke at a DPC summit earlier this year in Columbus. So last year we were the fastest growing DPC in Ohio. And we went to this, and I was asked to come and speak at this summit down in Columbus. So they're like, all we want to do is hear what you've done. It's not a lecture. I'm not telling people what they should do. It's like, I started here, I'm here, and this is my presentation on how I achieved it in my case. So I did like half an hour talk on it. And then I had half an hour arguing with these people telling me how they wouldn't have done it the same. And why did you do that? And I'm like, how many patients have you got in your clinic? And they're like, oh, we've got like 140. And I'm like, I'm maxed out and we're knocking on 900. At that time, we're over 1,000 now. And it's like.
Do you have a location on the west side? You don't? No?
Not yet.
You thinking about it? Yeah.
To be honest, it comes down to numbers. So at the moment, we're in a few negotiations, actually out further east of us, what might end up with some new clinics. But it really comes down to numbers. Like, if we had enough business in this area where we could be like, right, we need to open up we've got 300 patients to start a clinic, I'll open a clinic wherever.
Well, let me see if I can make that happen.
Yeah, because you do actually have a DPC in Rocky River.
Oh, is that right?
Yeah, but you've probably never heard of them, have you?
No.
There's one right here, but they're one of those like functional micro
Yeah.
practices.
Yeah.
They do like yoga during their visits.
Yeah,
and stuff.
I don't want to. Yeah, I want evidence-based
Yeah.
medicine. You know what I mean? I mean,
Yeah.
my primary is with Metro, but he's one of those guys, Jeff Galvin, he's seeing 30 patients a day.
I did my residency at Metro.
Yeah. I mean,
That
he's
place
seeing
is amazing.
Oh yeah, yeah. I mean, but it's funny. Like I'll be sitting in there, he'll come in there, be on the computer. He's a great guy. He's actually, I've been going to him so long. I'm a friend of his, but I feel for him.
Yeah.
Because it's
and again, nobody chose this, and doctors are the brunt. Look, why do you schedule 30 an hour? No, 30 a day.
I don't.
No doctor asked that. No doctor wanted it.
Yeah.
But we're the ones on the forefront, so we're the ones that are greedy and want to see all these patients, which is complete garbage. Yeah. We've just got to keep proving that we're making huge strides in kind of increasing the cost and effectiveness.
Right. So where do you see it going in the next 5 years? What's going to be new and different, and how's it going to change for DPC?
I mean, I think you're going to see huge growth in numbers. So DPCs are popping up all over the place. When I started 3 years ago, there was a couple of us around Cleveland area. Now we've got a pretty big network. I think what's going to be the biggest thing, though, is we're going to see it spread into the specialty areas. Mm-hmm. So there's a couple of areas which already you're seeing more of it, like especially like psychiatry, and we're seeing dermatology. We're seeing it becoming more popular, but I think within the specialties, you're going to see this happening more and more.
What about like MSK, musculoskeletal? Could it move into that area?
Yeah, I think so. I mean, it will certainly take some time before you could get MSK to the point of having like surgical centers, for instance. Right. But certainly kind of more your sports med, things like that. Absolutely, we're going to see it growing.
And what about staffing? I mean, I've read sometimes that there's a shortage of primary care docs. Is that impacting you all, or is that kind of a myth?
Depends if you're talking about, is there a shortage as a whole, or is there a shortage for us? Mm-hmm. For me, because we have more, what you've got to remember is no doctor chose to see 26 patients a day. No one went into medicine and thought, hey, you know what? I'm going to see 26 a day. I'm going to try and make a ton of money. I'm going to burn myself out, and I'm going to be miserable. Right. No one chose that. So with me, if I put an ad out and offer a competitive salary to see 8 patients a day and have as much time as you want and have direct contact with them and to be able to treat people how you believe they should be treated, there's not a shortage for us. We can find people all over. As a population, yes, there is a shortage. Right. But when it comes to staff, like nursing staff, admin staff, things like that, we do pretty well because we're a calm clinic. No one's running around, no one's yelling. We haven't got 20 people in our waiting room at a time. You know those people super well. So every single patient knows me. Mm-hmm. Every single patient knows my receptionist. Every single person knows our office manager, because we're very close knit, because we're low numbers.
So I have a buddy up in Milwaukee, and he's a primary care. And the thing that just drives him crazy is the paperwork, the insurance forms, and I have to believe that in your practice there's less of that. Is that fair or no?
There's less bureaucracy, because when you think about them, it's like, oh, you didn't put this exact code in, or you didn't put that code in, so that messes with the bill. We document in a way that is safe for ourselves and our patients. So I need to, if I saw you for back pain, I need to document that well enough that tells, let's say in a week's time, you come back and see one of my colleagues. That needs to be documented well enough that he can look at your thing and know exactly what's going on with you. Have the diagnosis and the plan and everything like that, but we're not serving administrators. If I put in a code as back pain, it's back pain. They might be, you coded this, but it needs to be this other similar code. So we get rid of a lot of that bureaucracy. So yes, we have to document, and we have to document appropriately, but we're not having to bend over backwards over tiny detail.
So what would you tell an employer about DPC, or what would be should be their next step if they wanted to learn more?
I mean, obviously, reaching out directly to us. I mean, I'm always happy to spread the word, and the main thing is just think about what you're trying to achieve. Are you trying to achieve good access for your employees? Are you trying to access good quality of care? Are you trying to access continuity of care? And at the same time, are you looking to limit your own risks? Because if you answer yes to even 2 of those, then DPC is the answer. And if you're saying yes to all of those, then really it's a no-brainer.
Do you provide the employers with utilization reports? So like, for instance, at Roundstone, we have a couple hundred employees. If we would sign up with Maple Health, you know, what happens if a third of our employees never respond to your phone calls and never go get care? What are you able to report to the?
Yeah, so we can give. I mean, we don't kind of like, obviously with privacy, we're not going to give out notes of what we're seen for, but we can run a report on either an individual or a company, and we can see how many times they've called, how many times we've had a conversation with them, how many text messages have they sent us, whether they were, how many were in hours, how many were out of hours, how many times they've been seen, things like that. So yeah, we can show utilization.
And would the employer pay for the whole population, whether they showed up or not?
It'd be entirely up to the employer. So it's much like any insurance plan where you can design it. Yeah. We have some companies who we're going to pay 100% of their memberships. They can pay for their labs and pharmacy. We've got some who are like, we'll pay for 50%. And we'll cover 50% of that. We have some which are, we'll cover 50% of employees and we'll cover 50% of dependents. So you actually have the complete freedom to set it up kind of however you want.
It would seem that if you want the folks to establish a relationship, the employer paying, at least for that subscription piece of it, 100%. Would make some sense.
And that's what happens most of the time. There's much smaller businesses are the ones that sometimes have some variation. But when you get into the bigger groups, especially the ones which are self-funded, the business is paying for it because they're also they're looking to shield those costs. So it makes much more sense for those bigger companies to pay the full amount because you're actually utilizing it to save yourself money.
Right. So this is the second time that you've chatted with Roundstone. I guess we did a webinar a little bit back and introducing the concept. And this here, our podcast, is a little different. Do you have any questions for me or Roundstone or what we're doing? Or
I mean, really, my main thing is how to get our 2 groups to get together because we have to have the brokers educated and we have to have them putting this out as an example. At the same time, when you put this out as an example, I need to be able to back it up with exactly what we've been talking about today. Need to get them in quickly, need to get them in efficiently, need to get the care being excellent from day one. And really, it's just like moving forward, how can we put those 2 things together and just make it beneficial for everybody?
Yeah, well, I certainly think the webinar and this podcast is a step in that direction. We distribute through healthcare advisors, brokers, and so they listen to these things. So they're starting to learn about it. But we do some other. We have a national users conference we call our Medical Captive Forum. You know, we have speakers there, so that would be a lot of advisors, a lot of employers go there. We also have a summit for advisors, and we have a training academy for young advisors. So we have a lot of platforms that we can bring you in and start, because we do need to educate. That's a big part of what we do, and teach not just the employers but the advisors as well, the economics of DPC. I think a lot of them don't have a good idea that, you know, our underwriters will actually reduce their expected cost with the presence of a DPC program. So in a sense, it's not really costing you anything because you're reducing your insurance cost while you're gaining access to this solution known as direct primary care. So, hey, it was nice chatting with you. I enjoyed it, and I'm sure we'll be talking some more.
Thank you so much.
Thank you.